Welcome to Clinical Convos, a show that provides bottom line answers to key stroke recovery questions. I am your host, Henry Hoffman, an occupational therapist and the co-founder of Saebo, a leading provider of stroke rehabilitation products. If you are a health professional or caregiver and want to get to the bottom line regarding effective treatment options, then you have come to the right place. This is episode 2 at the Clinical Convos, and we have a great topic today and an equally great guest. We'll be discussing the efficacy of electrical stimulation on stroke recovery. I'd like to introduce you to Dr. Al Bracciano. Al is an occupational therapist with over 30 years of clinical practice and research, as well as a professor at the wonderful Creighton University. He's an instructor and co-founder with PAMCA, which stands for Physical Agent Modalities, Practitioner Credentialing Agency. That's a mouthful. Al is the author of the Physical Agent Modalities Theory and Application for Occupational Therapists book. He is also the author of the IOTA Physical Agent Modality Position paper, and contributed to several rehabilitation textbooks, including Trombley's OT for Physical Dysfunction. Al, welcome. How are you?
Good. How are you, Henry?
Great. Well, why don't you take a moment to share with the audience more about your background and the great work you do?
I received my undergraduate degree from an academic standpoint. My undergraduate degree is in occupational therapy through Wayne State University in Detroit, Michigan. I have my Master of Science in Hospital and Health Administration through Central Michigan University. I have my doctorate in educational leadership through Western Michigan University. So I'm kind of picking up all the universities in Michigan. I have my fellow from AOTA for my work actually in China and in Asia, and also in education. I'm a professor at Creighton University. I'm also in charge of, I'm the coordinator for our distance pathway in Alaska. I helped establish a collaborative program at University of Alaska Anchorage. And so I'm in charge of that program as well. I'm also a visiting professor at Jinan University in Guangzhou, China. I'm a visiting lecturer at Yonsei University in South Korea. I'm a content expert, subject matter expert for AOTA in physical agent modalities. And I also was a content expert for the Department of Defense, U.S. Army, and that's where we developed a program of training for military OTs in physical agent modalities.
Wow.
And of course, I'm on a lot of committees.
Well, I'm sorry you haven't done much yet, but hopefully soon you can start to build up that resume. So PAMCA, tell me a little bit more about PAMCA for the audience, what that is, because I know we have therapists on here, we have patients on here, but for therapists, what is PAMCA? It sounds like it's a certification. How long have you been doing that, and what does that consist of?
We actually started that in 2004. It was actually kind of a spin-off of the earlier work that we had been doing in terms of trying to standardize the licensing laws, licensing regulations, the training for OTs. Like I mentioned, the Department of Defense noticed, that the training of physical agents for the military OTs at the time was all over the place. So they were looking to try to standardize that. And so as we developed that content, my colleague and I, Scott McPhee, we kept getting asked if we could train therapists at different institutions, hospitals, and things like that. And so both of us being educators and clinicians, we weren't satisfied with the usual continuing ed where you go to a class, no preparation, you get dumped with all this kind of information that you can't really process. There's no preparation to it. You might engage in different techniques, learn different techniques and things like that on site, and then you go away and that's it.
Right.
And so we were looking at adult education, adult learning theory as well. And so that's where we came up with PAMCA, the certification course in physical agent modalities, that essentially meets, depending on the state, you always have to check your state's regulatory language and guidelines, but it usually meets those state requirements for licensing in physical agent modalities. So we cover electrotherapy, superficial thermal agents, pharmacology, ultrasound, therapeutic ultrasound, essentially the whole gamut for physical agent modality.
So is that for occupational therapists and PTs, or is that primarily?
Yeah, we actually trained. Yeah, we've trained PTs, we've trained OTs. Our focus, of course, and intent is with OTs.
Okay.
because of those licensing regulations that we have that PTs don't necessarily have, because they have that training in quotes, as part of their academic program, which technically OTs do as well somewhat, but there's such variation, variability, with the academic training in physical agents,
Gotcha. And so if they want to learn more about PAMCA, what is the website for folks that want to learn more?
www.pampca.org.
Okay, perfect.
Or if they just Google PAMCA or physical agents, it usually pops up.
Yeah, I know.
That's actually, we do that in conjunction with Saginaw Valley State University. So
Okay.
the therapists that participate in that get 45 CEs. And then we also, do testing on site. There's modules, learning modules, course website. It's a really robust. Essentially, it's a 3-credit class.
Okay, well, that's wonderful, because I know a lot of the, at least as far as OTs, not up to par when it comes to modalities, and I know it's something that's definitely needed. So that sounds like a great credentialing program. All right, well, let's dive into some clinical eSTIM questions. I did have some sent in to the office, as well as I've created some that I wanted to make sure that I've asked you as well. So I was looking forward to this session together. So let's start with the first question. Oftentimes when referring to, as you know, eSTIM, it's alphabet soup, right? You hear NMES, EMS, TENS, ETS. If you could just spend a few minutes talking about what are the different forms of eSTIM. We'll stick to electrodes that actually go on your skin, and we won't get into transcranial or implantables, but what are the most common forms of eSTIM at this point?
The most common forms that OTs use and that are used clinically, the forms, and really APTA standardized the language for electrotherapy, because there's such diversity in terms of the titles and the names of the equipment that some of the manufacturers were giving. So when you think about electrotherapy and those concepts and those uses, it's really based on what you're going to use the machine for, the equipment for. For example, you mentioned TENS. You can't use TENS necessarily for a motor contraction, because it's not going to have the same parameters that neuromuscular electrical stimulation would have, NMES, which is the form that's most often used by OTs. The forms that are most often used by therapists are neuromuscular eSTIM, high voltage galvanic stimulation for ESTR for tissue repair. That's used for decubiti, wound healing and things like that. TENS, like you mentioned, transcutaneous electrical nerve stimulation is used for pain control. Iontophoresis is used for drug delivery. So it's a method of drug delivery that we can use for a whole variety of medications, and those are controlled substances in many cases. So those are probably the most common. Another one would be microcurrent, which is a form of TENS, and also iontophoresis. Iontophoresis is the drug delivery, but interferential current is also a form of TENS for pain control.
Right, and that's really good to know. And I know for our audience at Saebo, the two products we have are NMES units, and of course FES. People get confused with FES versus NMES, and of course I think we had this conversation offline, where NMES is going to be used more for your open chain exercise, just like EMS, where FES is more function-based, activity-based, and that's what I like about our Saebo Stim Pro. It has a trigger, so you can time the stim with the functional task that you want them to accomplish. And that's more than of an FES form. And also there's EMG triggered stim, which is, in my opinion, underutilized. I mean, biofeedback by itself in the profession is underutilized, but EMG triggered, what I love about EMG triggered, for the folks that don't know, is in order to receive the reward, the quote unquote reward of getting shocked with electrical stimulation, they need to first exceed a threshold of voluntary activation of a movement, or potentially deactivation of a movement, like a contraction or a relaxation. Once they exceed that threshold or go below that threshold, if they're relaxing the muscle, then they get the reward of electrical stimulation. So that's something that is one of my favorites as well. Well, that's really helpful.
And you bring up a really good point about, to add to that, because a lot of therapists, and if you look at the research, that's where it can be confusing as well. A lot of times the research will say that they're doing functional electrical stimulation when in fact they're using it for the neurological effect or neuroplasticity or, motor reeducation, motor return. And I always qualify and tell my students, functional electrical stimulation is essentially the use of electrotherapy, like you mentioned, for a functional task or activity. Most often, the system that you described is a good example of that. For foot drop, those kind of units for tibialis anterior, for foot drop, for gait and ambulation, that's a pure example of functional electrical stimulation as well. So it's the use of that as an adjunct to movement, to enable you to complete, some kind of ADL task.
Right.
Not
Well,
everything is functional electrical stimulation. A lot of OTs like to say, I'm doing functional electrical stimulation.
Right.
They're not. They're using it neurologically or from muscle re-education or strengthening.
Well, we'll save this thought for the next conversation, but one of the frustrating things I see all the time, and I'm sure you do too, is when patients go online to Amazon thinking they're buying a muscle strengthening eStim device, and it's a TENS for $19.95, and it's doing absolutely nothing to help with their weakness, but we'll save that one for next time. Now, another popular question, without getting too technical, is talking about parameters. So therapists are all over the place, and patients for sure are confused. What are the typical go-to for Dr. L? What is your typical go-to parameters for just general neuro re-education? If you're a stroke survivor, weak arm, weak bicep, tricep, weak wrist extensors, weak leg, in general, when you talk about your frequency and your duration and your on and off ratios or ramp as well, what would be your general go-to?
Let's start with pulses per second. Okay, so essentially, and this is for OTs, this is kind of difficult for them to conceptualize, but everything we do is we're applying force or energy to our patient for a physiological reason. Okay? It doesn't matter if we're doing hand-on-hand resistance, it doesn't matter if we're having them reach higher, it doesn't matter if we're having them manipulate an object. We're doing that because we're applying force to the healing tissue or the neurological system. And so the pulses per second essentially is the amount of energy that you're administering to the body. If you look at healthy tissue, healthy muscle tissue, it responds at about approximately 35 to 45 pulses per second, sometimes as high as 50. The higher the pulses per second, the more energy you're going to be giving that tissue. So you're going to have a different physiological effect. For neuromuscular eStim, we use most often anywhere between 35 to 45 or 50 pulses per second. For example, most of the equipment comes preset. There's usually a preset, parameter for most of these categories that you're talking about. And so that was what we would use for neuromuscular eStim, for neurological re-education, muscle strengthening, that kind of thing. If we had a spastic muscle, some of the programs that are already built into the systems, some of these units can go up to 70, 75 pulses per second because they're giving more energy to that muscle with the intent that that's going to decrease, it'll start to fatigue, get tired, so to speak, and then spasticity will decrease. The other way that we use it is for manipulating the pain pathways. So if we go to 150 pulses per second, most TENS units, conventional TENS units use 150 pulses per second. The theory behind that is that amount of stimulation will close the gate, and so it will control the pain. It's not going to have the same effect on muscle contraction, so to speak, that a neuromuscular eStim unit will, but 150 pulses per second usually will start to manipulate the gate, close the gate. So those are the parameters in terms of pulses per second. Those are also known as hertz. The other factor that we have to consider is the phase duration. So essentially, the easiest way to describe this, and I'm simplifying it, is how long is that zap going to last? How long do we hold it? Because when we hold that charge, that zap, a certain period of time, we're going to target different nerves. So for TENS, for example, 150 microseconds, if you hold that zap for 150 microseconds, we're going to target the sensory nerves, which are superficial. If we hold that a little bit longer, we're going to target the sensory nerve, and it's going to drop down and it's going to pick up the motor nerve at 250, 300 microseconds long. If we hold it for 400 or 1,000 microseconds, now what we're doing is we're going past the sensory nerve, past the motor nerve. We're actually stimulating the noxious level pain nerves. That turns on the opioid system, and so we have pain control. So that's why it's really important that you kind of understand those concepts, because we're going to be targeting different nerve pathways. We're also going to be applying more or less energy to either get a muscle contraction or to manipulate the pain system.
Got it. So that's real helpful.
And the last factor is really the duration. How long do you leave that thing on, and the amplitude. Obviously, if you turn the machine up as high as it's going to go, you're going to have a really strong contraction. But we always increase the amplitude to tetany, so the muscle grabs, holds, and the muscle contracts. The patient has that movement if we're looking at neuromuscular. And then in terms of neuro re-education, with our patients who might have hemiplegia and that kind of, we use a 1-to-1 ratio, 1-to-3 ratio, or 1-to-5 ratio, and we manipulate that. We use that as the patient starts to get return back, because we might want to build strength right away. So that 1-to-1 is almost like those. I always use the analogy of weightlifters. Pull the weight up, bam, drop it. Pull the weight up, bam, drop it. So there's very little rest, a lot of muscle strengthening, a lot of power in that contraction. Whereas if we have a patient who's starting to develop functional movement, into extension, we might use a 1-to-5 ratio. Give them enough in that neurological system, enough time to rest, the muscles to rest, so that they don't go back into overflow.
Okay, very good. So if you're classic client with weakness post-stroke, you're trying to work on wrist extension or triceps, sounds like your pulses per second is anywhere from 30 to 50. What would be the pulse width duration, you think, for that scenario?
250
pardon me?
250
Okay,
microseconds.
perfect. Yep.
Motor.
Good. So I think that's real helpful. I know that's similar to what that we recommend, and I know patients always ask, so hopefully they find that helpful as well. All right, well, moving on. Popular question number 3 is about contraindications. There seems to be a struggle finding a very good resource which talks about the up-to-date information on contraindications. Now, we probably get, at least I get, 5 emails every 6 months or so from therapists or clients that are worried about if they had a seizure, but they really want e-stim. They have a 2-inch gap subluxation. They're interested in our subluxation device, the e-stim device, the Saebo Stim 1, but they, Billy had 1 seizure 11 months ago. That's always something that pops up. Another one is, the patient has a metal implant or a rod or a knee replacement. Can they receive stim? So first question is, do you have a recommendation and a go-to resource for contraindications list that's up to date? And the second one is, what do you think about those 2 popular questions, at least that we get, the one about the seizure and the one about, I know there's a long list of contraindications, but the ones that are kind of a nuance is the occasional seizure, or if they have a metal rod or implant. Because I do know the guidelines keep changing on that.
I mean, from a website standpoint, I think Physiopedia, is pretty good. You can pretty much do a Google search and, contraindications for electrical stimulation, and there'll be a couple of good sites that open. Certainly, I mean, the textbook that I wrote for OTs and OTAs, I just revised that. 3rd edition's coming out this summer. That certainly has a whole list of contraindications. But most often, in terms of the questions that you get from clients regarding seizures, you never apply, and OT should know this, therapists should know this, you never apply electrotherapy transcerebral. The only form of electrical stimulation really, again, I'm just using those major categories that we talked about earlier, is cranial electrical stimulation, which is microcurrent, which we apply to our earlobes, which is used to put you in an alpha state and also to change the neurotransmitters of the brainstem. at the brainstem level. And so it changes the neurotransmitters, decreases pain, and it's FDA approved. That's the only piece of equipment you really should be applying to anybody. You never apply electrotherapy over the carotid sinuses, anywhere on the head or face. I mean, you have to be really careful if we're using it, and I've done this, used it with Bell's palsy, for example, or facial drooping because it's stroke. So you really have to know what you're doing if you're going to be applying it in those areas. And if you have a patient who has had a seizure, I always go back to the attending physician or to the neurologist and just clear it with them. If it's a distal extremity, it really should not be that difficult, especially if it's a kind of a transient seizure that they had, a year ago or something along those lines. In terms of ORIFs, or hardware, indwelling hardware, obviously if it's sticking through the skin, we never apply electrotherapy over those areas. But if it's, it depends on the location. I've used it, with a whole variety of different patients. For example, radial nerve injuries, where you're trying to, or tendon transfers, where they've transferred the tendons and we're trying to increase the strength, for example, at the wrist, and yet they have an ORIF, we're trying to get finger flexion or extension, but the ORIF, which is superficial, it's just underneath the skin of the dorsal surface of the wrist and forearm. There's not a lot of muscle on top of that. So it's going to be somewhat uncomfortable and problematic for those kind of patients. So again, it's really good training and knowing what your goal is with those kind of cases.
Yeah. So I made a mental note. So don't put the electrodes over the eyeballs.
No, it's actually funny that you say that, because there is research that was done on cranial electrical stimulation in Russia that they did put it over the eyeballs.
Okay.
And so that's something, I've got a picture of it. It's actually amazing. It's like,
I'm going to have to call some patients after this and apologize for my poor recommendation. Sorry about that, but thank you for letting me know that. All right, very good. Well, thank you for answering that question. There's also another opinion about lack of consensus, if you will, regarding how long you should receive stim. And, is this daily and how many minutes per day? Now, I, as a young therapist at Burke, way back when, and the way we were taught in school and our supervisors, I had no problem, foolishly, I had no problem having a patient come in twice a week to see me for, let's say, stroke, and offering 20 minutes of stim twice a week. And they didn't have a stim unit at home. And remember, let's say it's 10 minutes on, 10 minutes off. So it's really 10 minutes of my 20 minutes is real stim, right? So what was I thinking, saying to patients, come to my outpatient clinic, even if it's 3 times per week, and let me provide stim for 20 minutes, 10 seconds on, 10 seconds off. And we already know that that's not effective. As I sit here now, I mean, the youth is wasted on the young nowadays, right? So obviously I was not doing things correctly. And sadly, I hear from patients where they're still receiving therapy, and that's what they're still doing, and they don't have a home unit for carryover. So I know there's no silver bullet when it comes to the perfect protocol, but in general, what is your recommendation when it comes to how often if let's say it's not, we'll give you a specific, let's just say it's neuroread because they're hemiparetic and they have a weak arm or a weak leg. What do you typically recommend to your students?
That you bring up a great question, and the question really is the effect of electrotherapy dose related? And that question comes up a lot, like with ultrasound. Ultrasound doesn't work. No, ultrasound does work if you look at the research, but you have to increase the parameters, increase the dosage, increase the length of time. And the research in electrotherapy, literally in the past 5 years, I think it is, has quadrupled. There's a lot of new research that's come out that's really quite good. The question is, well, is it dose related? And like you, I was trained way back, when this equipment first came out. Lucinda Baker, the equipment really came out, from California, Rancho Los Amigos. They essentially had the problem the patients would go to therapy, this is years and years ago. they would go to therapy, they'd go back to the room, they'd sit there, and then they would sit there. And so the question that they had asked was, wouldn't it be great if these patients could exercise while they're in their room? And so that's where the biomedical engineers came up with the Respond 1 and the Respond 2 units, which, just so you know, I still have in my office.
Yeah.
But what they would do is the patients would go to therapy, then they'd go up to their room and the therapist would put the e-stims on them and then let it run the rest of the afternoon, essentially, or for an extended period of time. What they found was that was helpful in terms of outcomes. And it's interesting because, you had Dr. Stephen Wolf on your conversations last month, who I always refer to, because when you look at constraint-induced therapy, 2 weeks of therapy, 8 hours, 6 to 8 hours a day for 2 weeks, and essentially the patients could play piano at the end of 2 weeks of therapy, but that's very intense therapy. When you look at the research related to e-stim, the parameters are varied. There's a couple of really good studies, that have looked at what we call high dose compared to low dose. So 60 minutes, 3 times a week, or 3 times a week versus 30 minutes, 3 times a week. And what they found was it didn't matter so much, but and then they compared it to conventional OT and PT. And they found that either one of those two approaches were better than just doing the same old that we usually do with patients. So you want to incorporate, there's really no question that you want to incorporate electrotherapy into your treatment with your patients. That's pretty clear. But there wasn't really a difference in terms of outcomes. They both had better outcomes, good outcomes, in terms of return in the hemiplegic upper extremity using either of those doses. But the trick was a minimum of 10 hours a week was what was needed to reach that level. And then after that, the patients would apparently progress.
That's interesting.
So that's something to keep in mind. If you look at constraint-induced therapy, if you look at most other approaches, the longer the better. And like when I first started using electrotherapy, and Medicare would pay for it. So it was great because we could send it home so the patients could use it, because that's ideal, when they have that capability to use the equipment at home. And of course, then Medicare thought it was experimental, and so stopped paying for it. My feeling is, a minimum, if you're going to do it clinically, 30 to 60 minutes, 3 to 4 times a week. If you can get more time in, that's even better. If a patient can have a home unit to use, I always advocate for that.
Yeah.
For the carry over, and it just works out best.
Well, we'll talk about subluxation in a little bit, but this reminds me of the MP protocol where they did 6 hours per day for the subluxation. That was their recommendation. You build up to the 6 hours.
Yep.
So obviously they were onto something. And that's one of the things we do also recommend. All right, perfect. Thank you for that question. Now we're going to switch gears and do more. I don't want to call it a lightning round, but we're going to do something where I can get your thumbs up, thumbs down, and regarding your opinion. One of the things is e-stim is often recommended for many impairments. However, on the one hand, in some instances, there's good evidence for certain conditions on using stim. On the other hand, there's inconclusive data regarding whether stim is even worth using. And because of that, there's still confusion existing regarding, does this impairment really require stim or not require stim? So for the folks at home that do not have the time to wonk out like Dr. Al, right, learning the latest evidence, I thought it would be useful for you to help provide some clarity regarding, when should we use e-stim for these particular impairments, according to you, and when would it be a waste of time, money, effort? Because that, I think, will help the audience a lot. So therefore, let's have you provide a thumbs up, thumbs down. I'll give you a list. There's only 6 different types that we want to talk about, and regarding if you think it's effective. So the first one, you kind of talked about it, but let's get you officially on record. The first one is pain. Is that going to be a thumbs up or thumbs down when it comes to electrical stim? Okay. And if you can give us the 30-second qualifier. Yep.
Yeah. The qualification is that, if you're going to be treating pain, you have to use a form of TENS. That could be microcurrent, interferential current, but transcutaneous electrical nerve stimulation specifically for pain control. Some of the research, will look at the use of electrotherapy with a painful hemiplegic shoulder and say that neuromuscular e-stim does not work for the hemiplegic pain. It shouldn't work for hemiplegic pain because TENS is the form of electrotherapy that we use with different parameters to treat hemiplegic shoulder pain. You may have a decrease in hemiplegic shoulder pain in your patients when you use neuromuscular e-stim because of the muscle fatigue. And the muscle fatigue, when the muscle starts to fatigue, that does turn on the opioid system and then can decrease pain. So, but overall, if you look at the research related to pain control and electrotherapy, it's better than even medication.
Yeah, I agree 100%, especially with the whole opioid crisis. So thumbs up here as well. All right, number 2, I'm just going to keep it very generic. Weakness in general. Is e-stim, is that a thumbs up approach for efficacy? Or for, again, let's stick with stroke, or a thumbs down when it comes to the research? What's your opinion on that? Okay, thumbs up. And then again, do you want to add a few comments to that? Brief comments? Yep.
This is what I call the abs of steel question. My students, my students always ask, it used to be the guys, now it's the women, can you get abs of steel, using electrotherapy? Can you actually look like Arnold Schwarzenegger using electrotherapy? And the answer is, if you look at the research, yes. That muscle strengthening is based on the overload principle, which is what we use when we lift weights. And so, in fact, there's no difference between isometric contractions, exercise type muscle strengthening versus electrotherapy and use of electrical stimulation for muscle strengthening. In fact, if you look at the research, high-level athletes, that are training for the Olympics use electrotherapy in addition to conventional training because they can target specific muscle groups. And there's some really interesting research. So yes, you can look like Arnold. And yes, I did have 2 of my students, it was the funniest thing. 2 of my students came in class after we were talking about abs of steel, and they had purchased units that they found online to see if it would actually work. And so they wore them in class, wore them for the semester. And in fact, it did work on their
Wow.
abs.
I'm just making a mental note right here.
Yeah, my 2, well, it has to get through your 2 inches, of adipose tissue on your stomach.
Yeah,
Really,
more like 4 inches.
But there was also some research that came out in terms of patients who had spinal cord injury with productive cough, and using that same concept, the abs of steel belt, so to speak, or electrotherapy for productive cough in patients with, who have spinal cord injury, high-level spinal cord injury, because they suffer from aspiration, pneumonia, and higher incidence of mortality. And in fact, you could get a higher productive cough for expulsion, if you choked on an item or anything like that, by using this technique, which is huge.
Very interesting. Well, excellent. Yeah. Thanks for clarifying that. Definitely thumbs up as well on that one. We use STIM a ton when it comes to NMES, of course, or even FES, which we'll get into a little bit when working with our stroke patients. Okay, edema. Edema is another one that people ask about. Is e-stim worth doing for edema? What does the research say, and what is your opinion? Thumbs up or thumbs down?
The research, it could go either way. There's a couple different ways to approach edema, so I'll kind of go half and half.
Okay.
If you use electrical muscle stimulation, which is direct current, that's the form that we use most often for edema control. And so it causes this pumping reaction, and because that's what we're looking for, is the pumping action is what, brings the fluid back to the heart and then circulates it. So you can use neuromuscular e-stim. Let's say we have a patient with a Colles fracture, been immobilized for 10 weeks. Grandma gets her cast off, and now she has some edema. She's hesitant to move. We can use alternating electrical stimulation, try to get that pumping action of the hand, the fist, the forearm, to pump the fluid out, and also to increase range of motion on those kind of patients, from a musculoskeletal standpoint. So it does work, it can work. Some patients might find electrical muscle stimulation somewhat uncomfortable, because it uses direct current, but we use gloves, mesh gloves, and there's different approaches than putting your hand in a bucket of water, like when I first started treating patients.
Right. And I agree. I agree with you. I think it's definitely a tool you should use. Maybe the research is not very conclusive, but I've seen it as far as empirical data. I've seen the benefits of that. Okay. So we got a thumbs up, thumbs down on that one, a little half-half. Subluxation is the next one. Now, before you give your response, that's one that I've spent a lot of time studying. And what I want you to also talk about after you decide on your thumbs up, thumbs down on subluxation and stim is my biggest pet peeve is electrode placement. Because I still think for some reason, at some point people were taught, I don't know if it was school, but the popular electrode placements for decades has been posterior deltoid and supraspinatus. And I was one of those believers as well for quite a while in my career. More research came out over the years, and I looked at cadaveric studies, looking at proximal migrator strength muscle tests. And I've come to and plus I've read some of Shaw's work, and I've come to the conclusion based on the fact that most stroke patients, literally over half, have a rotator cuff tear, whether it's symptomatic or asymptomatic. And the fact that supraspinatus is, so that's one issue. If your supra is probably partially torn in half the population. If you're a stroke survivor, the second problem is supra is not a strong proximal migrator to begin with. It's more of a compressor. So as I learned more, I realized, that is not the best solution for electrode placement. So I really love the deltoids. I think they're the strongest proximal migrators. And I also like long-headed tricep because it inserts on the infraglenoid, and that's a real strong proximal migrator as well. So when we put on our Saebo Stim 1, we just wrap it right around the deltoids and it goes right up. Now, you may already know if I'm going thumbs up or thumbs down on this question, but let me hear from you on A, do you feel E-stim's effective for subluxation? And then B, what is your thoughts on electrode placement? And then finally, I want to circle back with how long should they be doing stim per day? Is it anything like that MP protocol from years past? Okay, floor is yours.
Tough question, but absolutely, we should be using E-stim with shoulder subluxation. And I guess we should probably have qualified this entire discussion earlier. When you look at the research related to electrotherapy, therapists, PT or OT, don't use it because they don't understand how these things work. They don't understand either the electrophysiology behind it, or if you're an OT, a lot of times we don't look at the movement piece that is also necessary. What muscles are working, what are the primary movers, what are the stabilizers, like you were mentioning. And when you get into the hemiplegic upper extremity, depending on the researcher that you look at, anywhere between 30 to 80% of patients who have had a stroke with hemiplegia will get pain in the affected extremity. That's not necessarily because of the stroke. It's like you said, it might be rotator cuff, it might be a tendonitis, it might be bicycle tenosynovitis, it might be a rotator cuff tear. So the therapist really needs to address those issues as well. You can't just ignore it because that pain, that hemiplegic shoulder pain, is not normal. There's actually a provocative test, I wish we had time. It's called a modified Mir sign that will tell you with 98% accuracy whether or not your patient with a hemiplegic shoulder will develop shoulder pain, so that you can try to avoid that. So that's the first thing. I think OTs in general, we really need to step up our game. The other issue is that they're going to get paid now for their outcomes. We're not getting paid for the amount of time we spend with our patient. We're going to get paid for two things: on their patient outcomes and patient satisfaction. So you better be proactive and you better be progressive, and you really need to up your game. That being said, when you look at shoulder subluxation, the research, I think most people do posterior deltoid supraspinatus, is because if you look at the earliest research that was radiographically, that used radiography as the outcome, see if there was reapproximation, that was there, that was the location. There's been other research that's corroborated those placements. But like what you mentioned, is that a functional movement? Because if you look at the research related to using neuromuscular E-stim with the hemiplegic upper extremity, you always want to try to pair active movement or any kind of functional return the patient has with the electrical stimulation. So you don't want it just to be passive. You want them to move with it. And like you said, essentially, your arm's just going to come straight back like this when it's going to elevate and come back when you use those parameters, posterior deltoid supraspinatus. That being said, that's the first location I teach therapists, just because we know it's going to reapproximate the humeral head. But when you look at functional movement and you think about the hemiplegic upper extremity in a flexor synergy pattern, thinking of Brunstrom stages of return, we want to get them from here to here.
Right.
So that's where we have to look at what muscles can do that. And there you go with your deltoids.
Yeah.
If you look at Brunstrom stages, abduction is going to start to return. So we want to strengthen that. So that's where I think the problem with electrical stimulation and use by therapists is, it takes a lot of creativity to look at what motor return is coming back, what muscles do I need to strengthen, where do I place my electrodes to get a more functional movement and pattern and contraction, that's going to strengthen and reapproximate that humeral head, and then hopefully get distal movement.
Right.
In terms of time, obviously, I'm always for the, I kind of dose related. I think, the more that we can get that on the patient, I think the better off they'll be, and then we have to progress from there. We can't stop with just, anterior, posterior deltoid, where we get reapproximation. And it does feel different. You're absolutely correct. But from there, then how do we progress the patient to a reach?
Right.
To a reach and then flexion. So we have shoulder elevation, wrist extension, and maybe a hand to mouth path.
Yeah.
And again, it's really contextual. I think, I've taught all over the world, in Korea, it was really interesting. When we were working on those more functional patterns after we got out of that, posterior deltoid supraspinatus, and we were doing these hand and, these reaching patterns and flexion patterns and more functional movements, I was working with the guys, and I turned around and was looking, to see what some of the women in the class were doing. And in Korea, they were putting on their makeup. They were trying to put on their makeup because in the United States, we would use, a reach pattern with flexion as eating.
Yeah.
But in Korea, what's of value to them is putting on makeup, getting ready, all those kind of different tasks.
Yeah.
And so it's a value to the patient, just like we always talk about as OTs. What's the value to the patient? What do they want to do? How do we get them there using the electrical stimulation, using the equipment?
Right.
That's the trick.
With that, and that's very good. That's a very good example. So I think we're 100% on the same page on that one, especially with the subluxation. And ideally, if they're super low level, stage 1 Brunstrom, no movement or completely flaccid, I'm going to tell them, just like the old MP protocol, build up to, multiple hours per day, because why not, right? Just get the contractions going. All right, we're running out of time. So we're going to make these last two super quick. The foot drop. Okay. So with foot drop, there's been articles over the years that, with these wearable eStim devices, and they'll compare them to AFOs, and they'll see which one's more effective. What I tend to see with these articles, I haven't read, I haven't been up to date in the last couple of years, is if you're not gonna really work your way out of that eStim device to clear your foot as far as long-term outcomes. Bottom line, from what I read, is if you want to clear your foot, you got to keep using the eStim almost like a prosthetic. But I didn't see studies that said you can actually get to the point where you no longer need the stim for your classic neurological patient. What's your thoughts on that? Is that still the case today?
Yeah, I would probably concur with that. You're going to be targeting tibialis and peroneals. But it's with my patients, it seems to be more subjective. Some patients prefer that neuroprosthesis, the electrical stimulation, rather than a traditional AFO or an articulating AFO. So I think it's based on patient preference.
Yeah.
In terms of the research, I do think, it's and again, I don't track that area as closely as I do the upper extremity, but it does seem to, there's that wall that you hit that you're going to have to use something. So that's why I do want to worry. And I've had patients, where their battery didn't work or their unit didn't work, and so they felt like they were stuck out in public, and kind of unstable.
Yeah,
So
there
I
is a
think
risk
that,
to that. There is a risk to that. We've had a lot of patients who use the combination. Sometimes they use our Saebo step device with a wearable eStim device, or they'll alternate. They'll use their wearable eStim on certain days. And if they're out of electrodes or battery, they'll then use the Saebo step. So there is some back and forth on that. I definitely recommend exercise, NMES exercise training, agonist retraining, in a seated position or a standing position, just doing normal NMES activities and exercises for their muscles that are affected, causing the foot drop. In this case, the tibialis anterior you mentioned earlier. So I would agree. I would say, definitely a thumbs up because it does address the weakness when it comes to foot drop and stim. Of course, feel free to use that combined with other mechanical devices. But as far as long-term benefits of walking, where you no longer need it, I think the data is still inconclusive on that one. So,
and you bring up a good point, and if you look at the research, pretty much for anything that we do as OTs or PTs, these are not large random controlled trials. And I think the design of some of the studies, like you mentioned, what happens long term? Can they actually get out of it? Maybe they didn't pair it with exercise, like you mentioned. And so I think the research design on some of these studies, it opens the door for more research, but trying to get more research is always
right,
the trick.
right. All right, good. Last one, and then we're going to wrap it up for the audience here. It's hand impairment post-stroke. So it's just hemiparetic hand. For me, this is normally a 30-minute answer right here. So I'm going to try to force you to stop after 1 minute, and I'll stop as well after 1 minute, which will be hard. But most patients, if they're spastic, you've already addressed eStim and spasticity. We know you can fatigue the muscle. But most patients who have stim and they have tone, they look like this. And we don't want patients looking like this, throughout the day what are we doing here, right? So typically what I end up doing is I have a eStim combined with some mechanical assistance, whether it's our Saebo Flex, our Saebo Stretch, or the Saebo Glove. And what we're doing is we're keeping their fingers straight. They're getting the stim. It kind of looks like this. But I also want to put them in a functional position because I do want them to attempt to actually do some FES, which means, okay, now we have the stim up here for extension. They go to grab an object, I trigger stim, get them to open. Or let's say they're flaccid and they can barely squeeze. Well, I'm not going to put stim on their flexors and have them do this. That's kind of bizarre. So what I'll do is I'll put them in a Saebo hand device, let's say the Flex, and I'll do stim on the thenar, hypothenar, maybe even the long finger flexors trigger, which gets them to come to grasp. And then I'll untrigger and let the spring system help reopen. So, I think, for my opinion, stim for hemiparetic hand is the hardest to do out of all the things we've talked about as far as function. And it's going to be the toughest battle. So the question is, what's the best way we can approach it? And so from my perspective, it's combining it with other tools and mechanical elements. And we use obviously the Saebo devices for that, or I'll do taping and other things as well. So I probably went over about a little bit over a minute. Let me give you the same respect. What is your thoughts in general about the hemiparetic hand and eStim? Thumbs up, thumbs down. What's your thoughts?
Okay. Definitely thumbs up. Yeah, definitely thumbs up. And you bring up that, that is probably the most difficult, location to treat and to strengthen, just because of the complexities of the hand. Like you said, you really do have to, it could be something as simple as, just a simple cock-up splint that, stabilizes the wrist so that you can get more of the finger movement in the opposition. The trick that most therapists don't think about is the electrode size, and the fact that you might need to cut those things down, or you might need to use pediatric electrodes. But from a functional standpoint, and again, this is not with it's the movement that the OT and the PT need to look at and to understand and appreciate what movements, what's stable, what's flexible, what's moving, what's articulating, what's not. And I'll refer back to there's, some really nice research that came out looking at the use of electrical stimulation in children who have a diagnosis of cerebral palsy and post-Botox, and that whole re-education that we do with those kids, in terms of patterning, we used to call it patterning years ago, try to, get them that functional movement into the upper extremity. And if you look at the research with those kids, it's effective. Electrotherapy is effective, but it's really understanding movement. And I think that's, can be a problematic for some therapists just because, we don't focus on that. I don't think enough in OT education.
Yeah.
So I completely agree with you. It's really the creativity, understanding movement, understanding what needs to be stable, what needs to be flexible, what muscles are doing that, and then walking through that and trying.
Well, that is a fantastic way to close today. And Al, this has been a fantastic discussion. And I appreciate your time today talking about all things eStim. Please keep in touch and definitely come back anytime to discuss more. I think I now have 5 more topics for both of us to discuss in the future. And of course, for the folks listening, if you enjoyed this episode or have any comments or experiences you'd like to share, please post your comments on any of our social media sites to let us know. Also, if you have any questions for me or about the technology and how you can obtain a free trial or learn more about Saebo, feel free to email me at hhoffman@saebo.com. Al, thank you so much for your time today. I know the audience is definitely going to appreciate your knowledge. And of course, I always appreciate it. And your time is precious. And I'm glad you shared it with us today.
It was a pleasure, Henry. Really enjoyed it.
All right. Well, thank you very much and looking forward to seeing you next time.